Okay, thank you and welcome. Thank you all so much for taking the time to attend our presentation. This presentation is Resolving Barriers to Involving Male Loved Ones in Eating Disorder Treatment, and this is going to be presented by Rebecca Brum, who is our Chief Clinical Officer at Within, and Joe Kelly, who is our family coach at Within, as well as an author and an advocate. This session is being recorded, and so I'm going to turn it over to our presenters now. Thank you.
Hi,
Hello.
everybody.
It's very good to be with you. I'm Joe, that's Rebecca, obviously. We're going to talk about some important topics that are based on research and also based on personal interactions that I, in particular, have had over the last 12 or more years with male loved ones of someone who has an eating disorder. I've written 6 books about fathering, and I've co-authored 5 books about eating disorders.
So it's such an honor to be presenting here with Joe today. Joe has not only been somebody who I really admire and whose work I really admire, but who I can honestly say has made me a better clinician and parent, and I think partner as well. So I love the work that we're doing together. And Joe, if you want to forward to the next slide.
Yes.
This slide here makes me think of what are the ways that we want, or that male loved ones want us? What do they want us to know about their experience of being a caregiver to somebody that they love? And that is not a question that really took a lot of space in my mind, if any, until I started to work with Joe. And in my work as an eating disorder specialist, I thought I knew the work of families and caregivers. And then I stepped a little more into that space and recognized that I needed to enhance those skills, enhance understanding the perspective of a caregiver, and how to help them be advocates to the work of helping their loved one recover. But when I thought about loved ones and advocates, I often thought about mothers. And so in my work with Joe, he's really helped to broaden that idea. And so I'm really excited about this work. And I think this is a clip that will help to demonstrate where male loved ones are and what they're hoping that we understand as providers and clinicians.
A note to you as you're watching. These video clips are not professionally produced, so you may have to turn up your volume to hear what they're saying. So here we go.
You can't just treat the client. I'm the client too. I'm half of my wife's life, and she's coming into therapy with whatever baggage that I have provided to her. And then she's coming from therapy with a whole lot of baggage that you guys are giving her that I have to deal with. And how I deal with that baggage is going to impact how the baggage is coming back to therapy later on. So if I'm not included in this, or if I'm not a part of it, it's not making your job any easier. It's not making my wife's job any easier. It's certainly not making my life any easier. It's just treating half the symptoms, or half the problem. I may be the problem for all I know. I've entertained the idea that, maybe the eating disorder is me. Maybe I'm the one, maybe if I was out of the picture, my wife's eating disorder would vanish. Maybe that's the issue. I hate being in that situation. I hate having those thoughts. Like I said, my wife has been in this for a long time. We've been dealing with this since the mid-'80s, and we've been together for a long time. We'll be married 22 years next month. And so I'm committed to it. Neither of us, wants to see that not work. And we have kids, and we do, and we absolutely love each other.
I've heard this clip multiple times, and it still feels gut-wrenching to me to hear him say, maybe I'm the eating disorder. And to hear how deeply distressing that is to him. I'm also repeatedly affected by this man's words because it demonstrates the level of his commitment to his spouse. He hasn't gone anywhere. He's shown up for 30 years. And I think that's something that I think is really admirable. And I really feel for him. So I think it's important to talk about who are we talking about when we talk about male loved ones. And I hope you'll have a better understanding of why we use the term male loved ones, which admittedly does not come trippingly off the tongue. I think a lot of us, when we first think of males who love our clients, we would think of these people. And if we, somebody said, well, think of some other people, we might come up with a few more names. And as you can see, some of these names come up, they right away reveal some of the challenges of engaging a male loved one. For example, a spouse or partner who is deployed overseas, or a live-away dad, biological father who does not live with his child. So there's logistical things that are very real when it comes to where male loved ones are and how we interact with them. And it's important to just, plainly state and understand that if a father does not live in the same household with his child, or a spouse is deployed to Europe, that person is still very important to our client. But there are a lot of other male loved ones who are in our clients' lives. And they're not people we would readily think of, but they're there. These are people who potentially care about our client and that our client cares about. So it's a rich resource. It's a resource that's untapped in many ways, but it's a very real resource that is, in fact, makes up a circle of caring for our loved one. It's also important to honestly and blankly say that some of the men in our clients' lives are jerks. They are not a positive influence. And I'm going to just acknowledge something for a minute, if you'll indulge me. I'm pretty sure that there are some people who are in this group together today who were abused or abandoned as a child by a man, and may have been abused or abandoned as an adult by a man. And I feel some responsibility for that. And I'll tell you why. Because I am part of a fellowship of fathers and a fellowship of men. It's not an organization or anything formal. It's we have a shared experience. We are a fellowship. And I think as a fellowship of fathers and a fellowship of men, we have failed in significant ways. Two ways in particular. One is we have failed by not holding our brothers accountable for behavior like abuse or abandonment, making it clear that there should be no tolerance for that kind of behavior. I think our other failure is that we have not celebrated and encouraged and made attractive the joys of being a man who is open and responsible and imperfect and committed, and there shows up. So those are significant failures. And I want to say that if it was your experience that you were abused or abandoned by a father or a man, I apologize for that. That should not have happened. There's no excuse, none. And I hope that you'll come with us for the rest of the time together as we talk about ways to encourage, expect, invite, and demand that male loved ones be part of the work we're doing. Okay, here we go. And there we go. So it is important that people abused or abandoned as children or as adults by male loved ones, they need to be heard. Their experiences have to be respected. And I think, most providers recognize that. And I think it's also really important that as professionals or amateurs, advocates, whatever, as providers of care, our experiences must not blind us to the potential of other male loved ones to help us reduce risk, foster growth, and contribute to healing.
I just want to chime in on this slide as a provider myself, Joe, to say this is one of those things that wasn't necessarily on my radar until we had discussions about it. And it kind of reminded me that what we don't know or what we don't have in our awareness can hurt us, as the saying goes. But I think the hurt us entails the work that we do with our clients and the relationships that we help them set up in the future. So I also want to step into a space as a clinician to say, I assume responsibility for not utilizing fully male loved ones in our practice and my practice, and stepping into a space of saying, I really want to do that better, because I think that it's not only in the male loved one's best interest, but in our clients' best interest and in their recovery's best interest. So where are the male loved ones at when we meet them? When they come to us, when they find that they have a family member who is needing treatment, where are they coming to us from?
She had a lot of back issues. She's had 3 back surgeries, 1 abdominal surgery, and I could wrap my head around those challenges. I understood those problems. There was something I could see, touch, feel, and understand. And the eating disorder, I didn't. It made no sense to me. I was very angry about everything with it and didn't understand where it was coming from, what was the underlying cause or the reason or whatever it is. I couldn't understand that. I couldn't grasp that.
Our wives are the sinking ship, and we're on the life raft, and it's leaking. But then everyone's trying to save the sinking ship, and we're over going, hey, we're sinking here too a little bit. Obviously, that's the more pressing concern. But this is a problem too.
that part where he talks about we're a sinking ship too, really reminds me that as providers, we really do need the family to play a role, especially when they are in a position to be helpful. And that when a loved one feels like they're drowning, they have less resources to help the person who's in need of the care. I think that this slide is impactful because we understand, it makes sense to us that when mothers and fathers are supported, that their psychological symptoms decrease, and that is impactful to helping the child or the loved one improve. And this is shown consistently against races, across the different ethnicities and socioeconomic statuses. But very interestingly, men are less likely than women to utilize these mental health services that might make them more likely to decrease challenging symptoms around their trauma or their pain or their suffering around having a loved one in their own pain and suffering.
And as this next slide shows, that impacts what our situation is as a provider.
I mean, I have patients that I've been seeing for 2 years where I've never met the dad. The mom brings the kid to every appointment. And sometimes if the child is not doing well and I say to the mom, or I even leave a message and try to call the dad and say, I'm concerned, your child might need to be admitted to the hospital. Please come to the next appointment. I would say I have a 50% success rate of getting the dad to come in. And a lot of it, I think, is because they can't fix it. They don't know what to do to make it better. And it's tremendously uncomfortable for them.
So I think one thing that's impactful in what the clip shows is that she's had a lot of times where she's never met the father. And I think that as somebody who has been with a lot of families, I often will hear a dad especially say, I don't know what to do to fix this, or how long is this going to take to be resolved? And I can feel that with them because it isn't like that. We as providers, I think, early on have some of those same thoughts about like, what do I need to do to fix this? And it's really about the journey. So our work can really be helping male loved ones understand that this is not a fix it thing, but that the fix to it is twofold. It's one, helping them to understand that they don't have to walk on eggshells, to understand that not walking on eggshells is a place that challenges the eating disorder, and that learning to fix it is really learning skills that we use in treatment, that we teach to other caregivers that support recovery. And if we're headed into the clip that I think we are, Joe, here.
No, there's one more slide.
Okay.
Here, the first question that comes up most often with male loved ones is, why does my loved one have an eating disorder, and did I make it happen? And then comes, can I make it stop? And I think it's, with working with male loved ones, it's really important to move away from the why question, because it doesn't lead anywhere, and move into the how question. How can male loved ones use the tools of recovery to support recovery and learn how to stop walking on eggshells? So let's say somebody says to us, well, just tell me what to do.
I think about, I always think life, oops, I'm sorry for that. I always think life gives me a unique opportunity to experience what I'm speaking about, what we're speaking about here today. sometimes we find that fathers can bring, or male loved ones can bring, strategies that are maybe unconventional. I think about an experience we just had today. My ninth grader is taking the PSAT as a ninth grader. So kind of for context, it doesn't matter until it's 11th grade. So it's really genuinely just a practice test today. But nonetheless, he's 14 years old and he got nervous about it. And he texted this morning to say, "I don't have a calculator, Mom." And I, was throwing my shoes on, getting ready to run out the door. And my husband stopped me to say, "Hey, does he need a calculator? Like maybe it would just be better for him to kind of tough it out. And if this is the practice test, he'll probably be pretty sure to bring that calculator come 11th grade if he doesn't have one today." So it was a reminder that often being able to kind of share strategies and share perspectives can be a place of building strength and kind of doubling resources.
A lot of times I felt alone, like I didn't know what to do, because I had no idea. I remember one night coming home and, "What do you want for dinner?" "Nothing, but you have to eat." "I want nothing." "How about pizza?" "I guess I could eat some pizza." "What kind of pizza do you want?" "Nothing." So I called up Roundtable. I ordered one thing off every section of the menu. It's disgusting. But she had a good meal that night,
So this is not, something that we would therapeutically advise, but it worked. So the research does indicate, identify what are some of the barriers that inhibit men from engaging in therapy with their loved ones' therapies. So we're switching things around a little bit. Sorry, I lost track, but we'll keep going. So let's talk a little bit about what the research tells us about these barriers. But I think the biggest one is male acculturation. That the way we acculturate men and boys to live their lives, and especially how they interact with or don't interact with their inner lives. So male acculturation values working to solve a problem. It's not uncommon to have a male loved one say, "Well, let's stop talking about it and let's do something about it," because talking isn't effective. Male acculturation encourages distrust of institutions dominated by females, which the mental health profession is primarily female. And male acculturation forces what I call generational cycles of silence, where fathers do not talk to their sons about important things. And we, as boys and adults, often do not talk to each other about important things. I've done many workshops for fathers over the years, and without fail, if I ask the men in the room, "Have you been changed as a man because you're a father?" they all say yes. Then I ask them, has your father or your stepfather ever said to you, ever told you how he was changed as a man because you are his son? Virtually nobody knows. And those who do know say, the most number one answer, "Oh yeah, my father did talk to me about how he was changed because I was his son." Then the number one time that happened was on the father's deathbed. So it's like, we may talk, but only in extremis. And this is one of the upsides of working with a family where there's an eating disorder, because there's the male feels an immense amount of distress, and so therefore he's more likely to talk.
I'm very fortunate. I've got very good friends. I can share anything with my friends, and I do. Except this. I could not talk about this. I couldn't do it. It was something that was too painful, too personal. It was painful for me, too personal for my wife, very painful for her. People don't understand it, they don't get it.
So what were you afraid might happen if you did talk to your friends about the eating disorder?
Probably afraid they were going to judge my wife, and I didn't want that.
So here's somebody who does talk to his male friends, but didn't talk about this because he wanted to protect her, which again, you know, we might not recommend doing that therapeutically, but it's his urge to protect is a sign of his love and commitment. Men are more likely to believe that a loved one's problems are due to a lack of motivation and resist the idea that a loved one has a mental illness. Male loved ones are more likely to believe children's problems are developmentally appropriate and they'll pass naturally. And they also believe that fathers don't matter to or influence daughters as much as mothers do. And you note a lot of this research is referencing fathers, stepfathers, because that's where the bulk of the, you know, what little research there is. Most of it has been about fatherhood. So there's still a lot more we need to learn.
So from a provider perspective, Joe was talking about a lot of pieces that would make it maybe more difficult to where a male loved one might have their own difficulties in engaging in treatment, in understanding or perceiving that there is an issue to treat, maybe thinking that they might grow out of it or that there's an overreaction to what's going on. And then we have from the provider stance, maybe our own personal bias of kind of seeing them in the background. And then in order to be able to recruit, engage, and utilize male loved ones, we really have to kind of challenge, see past, and be willing to conceptualize male loved ones to bring them and their strengths that they can offer to treatment recovery. So kind of looking at us now as providers, what are the behaviors or the attitudes that we as mental health providers, how might we engage or a lack of prevent the engagement of male loved ones in the treatment resources that we're providing? So I think a starting place is really understanding that engaging another piece of the puzzle, and this is just truth. I'll take therapist because that's what I am. That's the vantage point that I understand the best, but this could be a dietitian or it could be a psychiatrist. In eating disorder treatment, we are one of, hopefully, in a best case scenario, a multidisciplinary team. And so if we're engaging family as well and the treatment team members, we might feel that trying to engage another person in the work might just be more than we have for effort, and we might have a tendency to minimize that the effort that's going to take is going to be worth what we get, and how we can engage the male loved one. Maybe as I was when first started to talk about some of this information, some of this became a lot more clear that there were pieces I didn't know. And so maybe the fear of the unknown, the fear of, am I doing this right? Or this is a little bit different than what I just thought. And even the differences, I don't remember the book that I read, but it talks about some of the differences in the sound of a male's voice for a female sometimes can activate fear signals. So some of that, overcoming some of that. And we may even have beliefs that kind of the jerk word that Joe used early on, we may have a belief that stands in our way to make us think that male loved one is not teachable or closed to the idea that they could be engaged.
Just to repeat something said earlier. These barriers for the providers are also drawn from research into the interactions between providers and males. So this next clip speaks to the teachable question.
There was a significant amount of distress in the room at times. And I think initially I was surprised by the amount of, oddly, both motivation and frustration. So that a lot of the guys were coming in and really talking about how difficult it has been figuring out how to provide care. That was something that also was accompanied by the sense of, I really want to know how to do this. So tell me.
I love that he says that in the clip is, I really want to know how to do this. So tell me. Joe runs a male loved one group for our male loved ones for our patients in treatment. And I remember utilizing some of the techniques that he suggested with a husband in coaching, and then hearing it back relayed to me through the provider. And she relayed back to me saying, hey, that session really fixed my husband. He has just been so supportive. And I thought, oh boy, if I wish that were true, that it was just fixed, but really being able, and a technique that I used with him, and I think will come up in the later slides, was really kind of framing this. And I remember distinctly the conversation about his frustrations, that he felt like this was a choice that she was making and that she could just choose around that. And the coaching, kind of the framing it as really kind of coaching, and that we have a shared goal, and a little more firmly saying that I probably would in another session, saying to him, hey, that's not really helping us with our goal. So if we have the goal of kind of driving this ball down the field, and that's the extent of my football training, but if we have the goal of driving this ball down the field, then that belief is not helping us. We need to deal with the here and now, and this is what's going to help us with our goal. So further barriers for providers like myself is having little training in male acculturation and communication. I can honestly say that in the almost 17 years that I've been in practice, that this is the first time that I've come across this information. The acceptance and the almost demanding or insistence that we engage males in participation, right? That we, as the provider earlier said, so many times she rarely met the fathers. We accept that instead of demanding something different or insisting on something different.
And I think that, Rebecca, just quickly, I think that's part of our acculturation as males and females, that we're all acculturated to the belief that relational and emotional work in a family is women's work. Mm-hmm. And so it's like, oh, the male's not here, I might not even notice, and if I do, my default might be, well, that doesn't really matter very much.
Yeah. And I think this tendency to focus on a male loved one's skill deficits rather than assets. And I want to make sure we stay on time, but I think of my two children are boys. And so it wasn't until I had boys that, and they got into school, and I started to notice some of the differences in education. And there's a lot of parallel that I see in some of the discussion that we're having today, that boys aren't schools aren't necessarily set up to boys' skill sets in the ways that they learn. They're more so set up for female learning, and that's because they're largely run by females. This isn't a jab at anybody. It's just what we know and what we create. And so if we think
it's not anybody's fault, nobody's to fault. It's acculturation.
Yeah, absolutely. And I think that saying of you'll never know the true measure of a fish's gifts if you measure their gifts by their ability to climb a tree. So some things that we can do to effectively engage male loved ones, we can explicitly invite them. And this, Joe, I would love for you to chime in on this. I'm remembering things that you've shared with me that I've done in practice, which is really needing to kind of make that call. This isn't an email, this is a conversation.
Right. And it also to explicitly invite, and someone relates to the next one about never diss a man, because the disrespect phenomenon is really powerful for men. It's a kind of a visceral reaction. They're alert for it. So the explicitly inviting them, it does three things. One, it increases the chance that they'll show up. It gives you an opportunity to gain data from that person that you might not have been able to get from anybody else. And it's frankly a little bit of a ritual where you're saying to this person, you matter and you're important and we need you.
And I can say in practice as well, that tip was beneficial to say, to start to say, I really need your perspective on this. I don't have the whole puzzle here without your input. That was a way to engage, but it also was tenfold for myself because I really did start to gain the whole puzzle and gain somebody who could really contribute to the support network built around that person. And I think this last point, focus on assets, look for the love. Some of our earlier clips really demonstrated even strong reactions are people that are often looking to love, to support, maybe are reacting from fear because of their intense love. And so looking at even misguided ways of providing love and support as opportunities to be refined and to be provided skill.
Look for the love, look for the motivation. That sort of thing. Yeah.
This was enabled the dads or the loved ones and husbands to come into the treatment team. And it's not uncommon for individuals to have a mom with a subclinical eating disorder. And so then the individual actually had a parent who didn't have an eating disorder and could support them. So I just found that really helpful. And then they actually became more involved in treatment. So that was the other thing that I noticed changed, was they started showing up here at the clinic with their wife or their daughter. And they started calling me and asking questions and being much more involved. And so it was a whole nother support system. And, individual part of the family system that were able to come in and be a resource and support for the individual. So that was just really incredible.
And I love that clip because it really talks about being able to enhance the privilege of having two parents in a home or engaging more people into the support network. Because unfortunately, we do live in a culture where there are a lot of beliefs and acculturation to diet culture and some of the beliefs that circle around that. And so we can engage as many supportive people as we can. We lengthen or enlarge the umbrella of people that can challenge some of those unhealthy beliefs that might keep the eating disorder fueled.
And I think it's also important to note that what we're doing right now is we're all involving one another in something important that does not require us to be in the same room. So if one of Katie's clients has a father, Katie practices in California. The father is in laboratory can still be part of the process.
So more provider strategies really challenge that too busy excuse. That's often, I think we live in a world where we're all too busy. And so being able to say, I need you to be a part of this. We really can't move forward without understanding your vantage point on all of this. Understand, get perspective on how he views things, his role in the family, his part in all of this. Does he hang back? Does he maybe feel like mom is too heavy and kind of jumps in to rescue? We've seen all of those things. And so it's really important to understand how that whole dynamic happens. And this is a great suggestion from Joe about revising intake forms to even reflect that we want the engagement of male loved ones.
And multiple male loved ones. So, to be asking questions like what women and what men are influential in your life or in your child's life, and to cast a wide net. And so if your forums have, I think nowadays forums should automatically have at least 4 lines for parents, because step parents are parents. But if we make simple changes like this, then it starts to have an effect on the agency's outlook and our own behavior, and we're looking for those additional resources of men and women both.
We can interpret that, how can I fix this, or how long is this going to last, as expressions of the male loved one's fear and of their love, and really of the fear for their loved one. We can also view that as expressions of his own distress over the fact that his loved one is distressed. I think we've all felt that pain in our heart, watching a loved one struggle with something that we can't fix. And we can also view that expression of how can I fix this as the loved one's motivation to take action. We can take advantage of that. We can deploy male loved ones by giving them concrete things to do. I've really enjoyed being able to give emotion-focused family therapy skills here. I think that there are some concrete pieces of and flows within that framework that help the male loved one and all really loved ones have a good idea of what things are going to help build skill in the patient to replace the anxiety and stress management tool that is the eating disorder. And Joe, I'll let you talk to this one a little bit more. Because as a clinician, I love abstract and metaphor,
Right.
and I think having some context for this would be helpful.
Sure. And this also reminds me, you will get, or you may have already gotten a handout that has a lot more detail on all these things I'm talking about. And one of the key things in that handout, which we didn't have time to fit in here, was to frame the interaction as a coaching dynamic. And so, to me, abstract is something that's very theoretical. Metaphor is really powerful in coaching and in giving somebody concrete things to do. I use another football example. I say, hey, guy, you've been, for the last 2 years, you've been running a quarterback sneak up the middle and getting your head smashed in. How about we try a different play? Let's try doing this instead, engaging in this practice instead, which maybe is an end around, and that sort of metaphor, that kind of coaching approach is something that most men are acculturated to, they've had experience with, and they can relate to. Oh, I did put frame music.
You're that good, Joe.
Oh, geez. I should have reviewed the slides again this week. And one of the big things we focus on in coaching in our male loved ones groups is practicing the idea that again, and it's metaphoric, that they're experiencing, as a male loved one, I'm experiencing two different phenomena. I'm experiencing the authentic self, and I'm experiencing the eating disorder self, but that most of my responses and reactions are to the eating disorder, and I'm not seeing the authentic self. And when I learn tools to understand the differences, to tease out, understanding what am I experiencing in this moment, it creates a whole different approach where the man can say, oh, this looks to me like it's my authentic loved one. So let me, speak to them and show my love. And if it looks like it's an eating disorder, well, I'm not going to argue, because that doesn't get me anywhere. And I can say things like, you know what, my perception is that the eating disorder is what's talking to me right now, and I'm not interested in talking to that, and just calmly walk away. And these are just what I'm showing are just a couple of the tools we use. Okay, we're ready for the next thing, right?
Mhm.
You would come back after these groups and then say, oh yeah, and then I tried this, and you could tell that there was a shift and it worked. Something worked. So to me, the beauty is that it allows them to be close to their loved one again and to make that connection in a situation where I think they've been feeling pretty hopeless and helpless, kind of thrown up their hands. To bear witness to this connection, this reconnect with their loved one, was really moving.
Oops, sorry. Well, there was another slide that said time for question and answer. So now is the time for.
I want to just do kind of a quick recap. It's been nice sharing this with you, Joe, because it gives me a little space to kind of reflect on what we talked about. But just kind of a quick recap of all of it together is the idea that the realization, I think, as a provider of how to engage male loved ones is a lot of the same and a little bit different. And knowing how to engage just a little bit more, we can feel powerful to engage a whole nother set of hands in the recovery process, and relieve some of the burden that other caregivers might be giving. So there's just so much goodness that comes along with engaging a male loved one for all involved. Okay, so inviting questions.
Thank you so much, Joe and Rebecca. That was very, very informative. You provided us with so many resources and so many options on how to engage our male loved ones. I will go to the chat to see if we have any questions. It doesn't look like we have any thus far, but while we do have a couple of minutes before we close, just wanted to remind everyone that at the completion of each of your CE sessions, you will have a link in your dashboard to complete a survey. Once you complete your survey, you will then be given another option to download your CE certificate. If that is not happening or you are having issues with the dashboard, please let us know. My name is Jamie Singletary. I introduced myself at the beginning, but just in case, my name is Jamie Singletary, and I am the Director of Family and Alumni Programming for Within, and I am assisting with making sure that the logistics are running smoothly for the conference. So again, if you are not receiving links for surveys and certificates, please do let us know. Other than that, I will check the chat to see if we have anything here. We do not have questions. Anything from our presenters that you guys would like to add before we close out?
Well, I have two additional little video clips that might be.
Oh, we do have a question. Let me back it up. It
All right.
says, how do you recommend dealing with a father who doesn't understand differentiating the eating disorder from the client and is often too harsh on a child. Example, screaming at them during meals, not letting them get up from the table until a meal is completed.
I think my take on that is to, as we said earlier, to look, ironically, look for the love in that and look for the distress in that interaction. My guess is that this guy is in a lot of distress, and that's why he's being harsh and trying to control, and because he's trying to make it stop. And that's how we're acculturated to be. If there's a problem, let's fix it quickly, as quickly as possible. So I think what's required is to go back several steps and to look more, to look for what is, what's the motivation here. And so I would say two things. One would be to invite that man to speak with you on his own, and to approach it as, can we find some time to talk? Maybe even, can you come in and talk with me, because I want to get your take on what's going on. You have information and that I can't get from anybody else. So would you take just a couple minutes to come in and just tell me what you know? And that my interaction, my pose in that interaction would be, I'm not going to do any psychoeducation. I'm not going to do any therapy. I'm just gathering data. And, and I'm gathering data that I may already have, and maybe I don't. But either way, what I'm doing is I'm establishing that we're working together on this. You and me, we're working together on this. And then that opens the door to, at another interaction, to say, hey, let's talk about some things that might work for you in these situations, because I know it's incredibly upsetting and distressful, and painful for you to see what's happening to your child. So it's taking that approach rather than starting at how to make him stop what he's doing right now. And so I don't think we can get somebody to differentiate between the authentic self and the eating disorder self, but we can teach them how to learn the ways of differentiation, and it takes practice. And that's what we do in our male loved ones groups. We're doing a lot of, we have them log information about their own experience, or say, what did I notice that happened? Did it look to me like an expression of eating disorder or of the authentic self? And then the next thing is, what did I experience in the moment? What was I feeling? What sensations was I having in my body? And then what did I do or say or think next? So the focus becomes on what's my experience as this person who happens to be male in the room and in the interaction. And I want to be conscious of the time. Okay, good. And to understand that, if I stay rooted in myself and my own experience, then I can have a neutral and empathic response to the high stimuli of an eating disorder.
Mm-hmm. Very nice. We have two more that popped in. This one says, we have a client with primarily restrictive eating patterns who has been with us for multiple years of treatment. Her husband has become more discouraging toward her treatment. We've tried to engage him previously in the past to help him with his desire to fix and teach him skills with no success. Currently, he is pushing her to lose weight and also discontinue treatment. Any immediate recommendations?
I think that my immediate recommendation, and Rebecca, you should jump in here too, is that sounds to me like somebody who we haven't succeeded in well, it's somebody we need to engage more. And, to look at what strategies have we been using to engage him? in the past. And if some of them have worked, let's do more of that. And if none of them have worked, then let's look at some of our assumptions and some of our strategies that we're using. And also to have tools to give him, you know, concrete tools, not abstract ones, concrete tools, like, you know, like this log I was just talking about. That you know, that's the way to get to the to make progress, and may not be able to make progress too, but
I'll chime in too, Joe. I think that both Jenny and Laura, this answer will help to with both of those pieces. I find that the two most helpful and important things that I've done with male loved ones in treatment is helping them psychoed. And really, I have a sheet that I use that I'd be happy if anybody wants to email me, I'd be happy to send it. But I have a sheet that I use that contrasts current culture with diet culture, and I'm sorry, current culture with recovery culture. And I really, especially for those that are a little bit more resistant, as in Laura's question, a little that are more resistant to the idea or skeptical of non-diet culture, I will use that to help them understand, you know, okay, regardless of if it's right or wrong, you have your opinion about these things, but this is the belief system that works for those who are moving into recovery, and helping them understand that the modulator for somebody struggling with an eating disorder is not working. They struggle to see the gray in diet culture, and so they just need to move away from it. That we need to build them into a recovery culture in order to have them be well. And I frame it as this is a fish swimming up a stream against a billion fishes going the opposite direction. And we need to teach you the skills so that your loved one doesn't have to swim alone. And kind of being poignant in that example of your loved one is trying to do something that's very difficult for them in their experience. These are the beliefs that are going to support their wellness. So we're not arguing about that. Go ahead, Joe.
And the other thing is that I found very helpful is really hammering on the idea this is a disease. This eating disorder is a disease, and so we often use the analogy of cancer. You know, if your loved one had cancer, would you want to know why? Well, yeah, but you know, it'd be easier for you to understand that. You know, I can't answer that question. Would you blame yourself for them having cancer? Well, I might, but a minute's reflection say, nah, I can't make that happen. I can't make cancer happen. Well, this is very similar. This is an illness, and you know, cancer can require multiple treatments over time. It may return. Or, you know, this is an illness. It's not a choice. It's not a moral thing. It's a disease. So treat it like you would any other disease.
And I think to add to Joe's point, you might ask those questions, but the most important thing would be, how do we get this person well? The number one question is, we can ask those questions later, but the number one thing is now, how do we get this patient well?
Right. And what are the concrete things that I can do as the partner to facilitate that? How can I use the tools of recovery to regulate my own discomfort and distress and rage?
Yeah. And I said two things, and I realized I didn't say the second. The other thing that I think has been really powerful is what we do in treatment anyway is externalizing the eating disorder. So really helping them understand that the eating disorder eclipses their loved one and sometimes takes over, and that is the voice of the eating disorder, and that they can choose to engage that or not. They can use the skills that we would use. We can teach them those things to say, but you know, I wonder if this sounds like your eating disorder, or they can start to see the eating disorder difference when that has kind of taken charge. And that's been really powerful.
I think we're out of time.
We are at our close. Thank you so much again to the both of you for taking the time to share this wonderful information in this space with all of our attendees. And for our attendees, we appreciate your time, we appreciate your presence, and we hope that you continue to log on and enjoy the rest of the summit. Thank you so much and have a wonderful day.
Thank you, everyone.
Thank you.
Thanks, Jamie.
Thank
Thanks,
you.
Jamie. We'll let you go on to what you got to do next.
Sending
Bye.
you a lot of support, Joe. Have a good day, okay?
Okay.
All right.